Bismillah ar-Rahman ar-Rahim. Will be our lecture about the basic of the ECG. By finishing this lecture, we have to understand the basic of the ECG and know how to read and interpret the ECG and diagnose the common problems that can be diagnosed by the ECG. Okay, and the goal of this academic session is to have the basic understanding of the ECG waves and intervals. So ECG is only waves and intervals. Waves and intervals. If we understand these waves and intervals and know the normal, we definitely know how to diagnose the abnormalities and to know the problems, the common problems that can be diagnosed by the ECG. This means what's interpretation of ECG. Interpretation of the ECG. Okay, we have to take a glance about the history of the ECG and how it was invented. 1842, that is a scientist called Carlo that he said that the concept that the electricity is associated with the heartbeat. It is a concept. In 1895, William Ensovin credited for the invention of the ECG. So the ECG is invented by William Ensovin. If you have the physiology of the electricity of the heart, definitely you know the Ensovin or the famous triangle of the Ensovin will come through this, inshallah. Again, in 1906, Ensovin using a string electrometer, this is the first ECG machine, and diagnosed some heart problem by using this string electrometer. Again, Ensovin got Nobel Prize about his work in physiology of medicine. This is 1924. So, ECG invented by William Ensovin. This is in 1895, and in 1960 he was able to do and diagnose some problem by using a string electrometer. We will see here, this is the first ECG machine. Here, this is the first ECG machine. It is a very bulky machine. If you see this man now, his arms and legs were in this, I think this container here, if you see, works as electrodes, and on one foot being immersed in a jar of salt solution. This big container contains salt solution, and this works as electrode. One foot and two hands are immersed in this. This is to know the history and how the ECG invented and how the machine was bulky on that time. This is by solving. Electrocardiogram. What is the electrocardiogram? It is a simple representation of the electrical event or activity of the cardiac cycle. This is an electrical event. Each event has a distinctive waveform. So the hallmark of the ECG is the waveform. The study of this waveform can lead to greater insight into patient cardiac pathophysiology. So, all the study in this waveform, we have to understand this waveform. It is duration, and it is shape, and it is elevation and inversion and depression. Like that, we are going to diagnose most of the problem of the that can be the problem of the heart that can be diagnosed using the ECG, and we'll know this here. Uh, of the ECG can identify the first thing that is, is arrhythmia and ischemic heart disease. Number one, arrhythmia. You can diagnose ECG arrhythmia using ECG. You can diagnose ischemic heart disease and like acute myocardial infarction or chronic ischemic heart disease, whatever it is. Arrhythmias like tachycardia, ventricular tachycardia, or atrial supraventricular tachycardia, and so on. And even the tachy or bradyarrhythmia like heart block. This we can use the ECG to diagnose this problem. Pericarditis, acute or chronic, and left ventricular or chamber hypertrophy, that like left ventricular hypertrophy, right ventricular hypertrophy, all can be diagnosed using the ECG. And definitely we can use ECG to diagnose electrolyte disturbance, for example, hyper and hypokalemia and hypercal and hypocalcemia. Drug toxicity such as the digoxin and any drug that prolong the QT interval, such as the antiarrhythmic drug itself, such as procainamide and amiodarone. All these drugs can cause prolongation of the QT interval, so that you can use the ECG to diagnose this prolongation and the effect of these drugs on the heart, the prolongation of the QT interval. Okay, and many other problems we can use to diagnose ECG, and also we can use the ECG to monitor the. This is one part of the vital sign of the heart. Definitely, this is by calculating the heart. If you want into the ICU, you see is the monitor that contains the ECG waves. This monitor used to definitely monitor the vital signs of the patients and the patient's general condition in the intensive care unit or in the operating room. And other a lot of uses of the ECG in the medicine era. Recent advances have extended the importance of the ECG. It is a vital test for determining the presence and severity of myocardial ischemia function, definitely localizing sites of origin and pathway of the tachyarrhythmia. Definitely, this is one that means ischemia. Two, arrhythmia. Assessing the aortic option of the patient, the heart failure. Definitely, we will see this in the in the treatment of heart failure, especially those patients with left bundle branch block, and using a device in treating the heart failure. Number four, as you know, you have some hereditary problem of the heart. That is that's some genetic disease causing arrhythmia such as Brugada and canulopathy. You can use ECG to diagnose such problems. Other use of the ECG, such as using the ECG, uh, this is prolonged monitoring of the ECG and diagnosing problem by using what's called 24 or 48-hour continuous ECG monitoring to diagnose some problems such as heart block or arrhythmia that are intermittent. Okay, we can speak about the physiology and fundamental principles that we use that generate electrical activity in the heart. Definitely, here we are speaking at the cells level and what's happening through the cell membrane that they create the electrical activity on the cell. Transmembrane ionic currents are generated by ion flux across cell membrane and between adjacent cells. That is what's creating the current. That the flux, the influx and efflux of the ions such as sodium and potassium and calcium. And you know what's called, these currents are synchronized by the cardiac activation and recovery sequences to generate cardiac electrical field in and around the heart that vary with time during the cardiac cycle. Okay, this synchronization of these currents that lead to cardiac cycle and cardiac activation and recovery sequences. This is definitely generating the electrical field. The current reaching the skin are then detected by the electrode placed in specific location on the extremities and torso that are configured to produce lead. Okay, the idea is that this current reaching the skin, and then we can detect this current by electrode. This electrode can be placed in specific location on the extremities. So if you see, you can put this electrode in the extremities and torso in the chest wall that are configured to produce leads. This electrode produce lead, and we will see this here in the coming slides. Okay, the depolarization. What is a depolarization? That's a contraction of any muscle is associated with electrical change called depolarization. You know the depolarization and depolarization, and that create this electrical current. This change can be detected by electrode attached to the surface of the body. That was CC so. The idea is muscle contraction and the depolarization and the that produce depolarization and depolarization, and you can detect this change, electrical change, by the electrode that attached on the surface of the body. And we have the repolarization, that is the phase of recovery or relaxation. So that this depolarization and repolarization, the dipole moment at any one instant during recovery is less than during activation. Recovery is a slow process, lasts more than 100 or 100 milliseconds or longer, and occur simultaneously over extensive portion of the fiber. That is at the level of the cell. So okay, pacemaker of the heart. So we'll talk about from where the electrical activity or the electrical current of the heart starts. What's the pacemaker of the heart? This is the cyanoatrial node, SA node, cyanoatrial node. This is a dominant pacemaker with an intrinsic rate of 60 to 100. So pacemaker cyanoatrial node is an intrinsic rate of 60 to 100. The AV node, it's a backup pacemaker with intrinsic heart rate of 40 to 60. Okay, the location of SE node, you know, it is in the right atrium, the junction of the superior vena cava and the right atrium, and from which it is the pacemaker of the heart. This is the first discharge of the electrical current start from the cyanoatrial node, then through a fiber in the right atrium, it goes to the AV node, which is located in the junction between the atria and the ventricle. And the AV node then and they have an intrinsic rate of 40, 60 to up to 60. So if we have a problem between the cyanoatrial node and the AV node will take the discharge of the current with a rate of 40 to 60. And this is here we are talking about the conductive system of the heart, and from which where the electrical activity start up in the cyanoatrial node, and then to the AV node, and then to the uh, bundle of his that have two branches, right and left bundle branches. Okay, so after the AV node, we have the ventricular cell. These ventricular cell in the this is what's called another backup pacemaker. If we have a heart block, then the ventricular cell have its own rhythm that with intrinsic rate of 20 to 45. So here, if the patient has a problem of heart block, that means that electrical activity it does not come from the AV or the cyanoatrial or the AV node. We have some block in this conductive system after the AV node. So here the ventricular cell will take the activity of the heart, giving a rate of 20 to 45. So the patient with complete heart block usually have a very slow rate of around 20 up to 45 beat per minute. So if you find a patient with bradycardia with a slow rate around this rate, definitely assume that patient have a complete heart block. Although we have what's called sinus bradycardia, it is usually the rate above 45, 40 in the patient with sinus bradycardia. This we already talked about this. This is the normal conduction system or the conductive system of the heart rate, which start from the cyanoatrial node. As I told you, it's here. It's located here. Sorry, it's located here. Here was a pen. Okay. Here is the cyanoatrial node. The junction between the right atrium and the superior vena cava. And here, then the electrical activity started from cyanoatrial node, giving a rate from 60 to 100, and through fiber in the right atrium to the AV node. Here, this black dot here, this is the AV node, which is located in the junction between the atrium and right atrium and the ventricles. And this it will give I told you before electrical from 40 to 60 electrical intensity rate. And after that, here this is the bundle of his. This has two branches, left. This is the left one. The left one also has two fascicles, that is the anterior and the anterior fascicle, left anterior fascicle, and the posterior left posterior fascicle. This is the left bundle branch, and the second is the right bundle branch to the right ventricle. Here it is the right bundle branch to the right ventricle. These two bundle branches then give Purkinje fibers. These Purkinje fibers that spread the electrical activity into the muscle or the myocardial cells. Here, these are the Purkinje fibers here, and also we have Purkinje fibers, the right bundle here. Okay. Okay. Look how it swears here, and now we have the P wave. Okay, and this is the QRS complex, and this is spread of this is T wave. Again, and you see the activation of the atria give us the P wave, and then the spread and the activation of the ventricle gives the QRS complex, and this is the relaxation phase, gives the deep repolarization, and the T wave. This is a relaxation phase. See here, we have the P wave. That's on the P wave, the constitute of the uh, the the atria activation and the AV node delay. See again, this is a AV node delay, give us the P wave, and then we have the depolarization and activation of the ventricles that give us the QRS complex. So here, these are the waves. The hallmark, to do the hallmark of the ECG here is the waves. We have P wave and QRS complex. That's Q and R and A S wave, T wave, and then we have the U wave. These are the waves of the ECG, and we will talk about them in detail, and should know their duration and their interval and their abnormalities and their progression. All this, the progression of the R wave that we should know, and the abnormalities uh, uh, of this duration and wave shape. We should know the normal and abnormal about that, and this is the hallmark of the ECG. Okay. Okay, we talk about the modern ECG instrument. Here it is. It is very simple. And you have the only you see here, that is the ECG. You can read the ECG before printing it out. We have the leads that are attached to the patient here, to the chest here wall. The ECGs are attached to the ECGs are attached to the chest wall. Here in this patient, this is the chest wall and this is ECG, and we have the limb or the extremity lead, this one here. This is the modern ECG lead. This is the modern ECG lead. Okay, we'll talk about this here, ECG leads here. So the ECG lead, they are measuring the difference in electrical potential between the 2 points. So we have 2 points, and you have what's called bipolar and unipolar lead. The bipolar lead, 2 different points on the body. We have 2 different points on the body, and the unipolar lead, we have 1 point on the body and the virtual reference point with 0 electrical potential located in the center of the heart. So I'm sorry, the unipolar lead using 1 point on the body, and the other virtual point is the center. Assume it have 0 electrical activity or potential. This is located in the center of the heart. But the bipolar lead, we have 2 different points on the body. Okay, you will see this here. So the ECG leads, we have a standard 12 lead ECG, 3 standard limb lead, and 3 augmented limb leads, and the 6 precordial or chest lead. This is the standard ECG. It should be 12 leads, 2 standard limb, augmented limbs, and the standard limb, that means they are bipolar, and the augmented leads, that's unipolar, and the precordial lead, all of them are unipolar, 6 precordial or chest lead. Here we will see how we record the ECG. These are the limb leads, that's lead 1, 2, and 3. These are the standard lead. That means they are bipolars. They require 2 sensors on the skin to make the leads. These are the standard lead. If one connects a line between 2 sensors, one has a vector. If these 2 sensors, for example, one lead in the left arm and the other in the right arm, These are 2 points. We connect them together. This give us the vector. Okay, they will be a positive and of definitely you have a positive and a negative uh, electrode edge. The positioning for lead 1, 2, 3, 1, 2, and 3, and the first given by the insolvent triangle. This I will tell you here. This is the insolvent triangle. So this is the standard lead here. We have to give a balance. For example, for lead 1, we have the negative end is on the right arm and the positive on the left arm. For lead 3, we have the negative on the left arm and the positive on the left leg here. And for lead 2, we have negative on the right arm and the positive on the left leg. Okay. Simply like that here, you see. This is the right arm here, and this is the left arm here, and this is the left leg here. For lead 1, the negative end is on the right arm and the positive on the left arm. For lead 2, the negative end on the right arm and here, and this is a positive on the left leg. For lead 3, we have the negative on left arm and the positive on left leg. This is the famous insolvent triangle for the standard limp leads. Limp leads, the standard limp leads, that means they have 2 points, negative and positive. Okay, if you connect the 2 points together, this give us the vector here. This is we call the vector. This is the vector for lead 1, and this is the vector for lead 3, and this is the vector for lead 2. Okay. Okay, again, if we use the angles you see the horizontal and the vertical, the vector line, and we use them, and we use the angles. We can use the angle to locate these standard limb leads. Here, if we see here the limb lead from the orthogonal triangle there lie on positive 0 angle, for lead 2 on positive 60 angle, and lead 3 on plus or positive 120 angle. This is the vertical and horizontal lines only, and the correspondent lines that or angles that the limb ECG lie on. It is very simple. Just we have to keep it like that. Don't bother by them. And here, this is for the augmented lead. Augmented lead. They are here using the center of the heart as the other end of the vector. For the AVR, all the 3 lead use the center of the heart. This is the unipolar. Augmented limbs are unipolar. That means they have one electrode, and the other electrode is the virtual one. For all of them is the center of the heart here. So this is we call them AVR, and the AVR here correspond to angle minus 150, and the AVL for angle 100 okay minus 30, and the AVF that use the left foot as located on the this angle plus 90. So we have to keep them AVR minus 50, AVL minus 30, and the AVF they use the foot is for one vector, and the other vector is also, I mean the other end is the center here, and the other in the left foot. AVR for the right arm, using the right arm, AVL using the left arm for one end, and the other end the center, and the AVF using the left foot, AVF for left foot, and the other end is in the center here of the heart. Okay, if we take all limbs leads together, the augmented limbs and the standard limb together, we can get this shape. They are all together. You can take a glance of them, and just we have to keep like that. Okay. This is where to put the standard chest lead and the limb lead ECG on the body of the human being here. If you see here, you have the limb, the chest limb first here on the chest. Sorry. Here, these are here. This is where to put the the chest leads. We call them V from V1 up to V6. V1 up to V6. They are 6 chest lead. We use them. Okay, here we have V1. That's the positive electrode placement. We can put it V1 here on the fourth intercostal space to the right of the sternum. This is in the fourth intercostal space here. This is the fourth intercostal space to the right of the sternum. Okay, V2 in the fourth intercostal space to the left of the sternum. The same, that one in the right, V1 on the right, and V2 on the left in the fourth intercostal space. Okay, V3 we put directly between V2. This is the V2 here, and V4 we put just here. This is a V3. About V4 here we use lines. It's called, we use the fifth intercostal, put it in the fifth intercostal space at the left mid-clavicular line. This is the mid-clavicular line. That is a virtual line from the mid-clavicular down. This is the fourth electrode lead. For the fifth electrode, here we use the also virtual line. What this is called? It is in the level with 4, but at the left anterior axillary line, and the fifth intercostal space in the virtual line of what called left anterior axillary line. Lastly, for V6 level with fifth in the same level, this is fifth intercostal space. Here we use a virtual line that's called mid-axillary line. Okay. This placement of this chest lead, look at view a special part of the heart. For V1 and V2, this view the septum of the heart, and V3 and V4 view the anterior wall of the heart, and V5 the lateral, and V6 the lateral wall of the heart. Sorry. Okay, this is about the chest lead. Okay, for right now we have to know this is standard 6 chest wall lead. Also we have what called the right precordial lead. We use the same position, but we put them in the right. Here, these are here, and also we have also we have the posterior lead. We have our posterior lead. This is called V6, V8. We have V8 and 9. V8 and 9. V8 and 9. This we put them. Here we call these are 15 lead ECG. This is to detect the posterior myocardial. We put them in the close to the spinal column. This is the position of the posterior lead. Here you see how it looks. I told you V1 and V2 just view the septum of the heart. These are called the septal lead, and the V3 and V4 view the anterior part of the heart. And okay, here the anterior, and V5 and 6 view the lateral wall of the heart here, and V4, V5 and V6 lateral wall of the heart. Okay. what is the ECG paper? It's a very important paper. It was designed for a purpose to detect the amplitude or the what's called velocity of the ECG, and so we can determine the heart rate just from the ECG. Here, if you see the ECG paper here, I have one big square. This is one big square here. One big square. If we just magnify here, this one big square, and this is divided into 5, 1, 2, 3, 4, 5 small square. Okay. We have the vertical and the horizontal lines of this square represent something in the ECG, and you have to know this very well, and this is very important. You see here, one big square equal 0.2 second or 200 milliseconds, the same 0.2 second equal time. This is time, you see. So this is why the ECG detect the velocity of, or you can detect the heart and know the heart rate by just reading the ECG, because the ECG paper measure the time, and one big square equal 0.2 millisecond, and this is one big square divided into 5 small square, so one small square equal 0.04. One small square equal 0.04 millisecond. 0.04 millisecond. Okay, this is about the horizontal. And so what the vertical, the ECG represent what? Here you see the vertical ECG length represent every 5 millimeter, or it represent 0.5 millivolt. So it represents the amplitude of the heart, the amplitude of the electrical activity, and it is measured by the volt. فرق الجهد بالعربي فرق الجهد. And يعني so this the vertical line or represent the represent here yes, it represent the amplitude of the heart of the electrical current. So one big square vertically represent 5 or 0.5 millivolt. This is very important. We should understand the importance of measuring the amplitude and the duration of the ECG just by using this ECG paper here. Sorry. Sorry, something wrong. Here horizontally, one small box. This is why I talk about one small box represent 0.04 second, and one large box 0.2 seconds. And vertically, one large box represent 0.5 millivolts. This is the amplitude. Okay, we have to understand this very well. This is basically very important in determining a lot of problems or diagnostic problem of the patient. So now we will come to clinical interpretation of the ECG. Accurate analysis of the ECG require thoroughness and care. One should be very careful and read the ECG thoroughly. Okay, not in part. The patient age and gender and clinical status should always be taken into account. Many mistakes in the ECG interpretation are error of omission. Therefore, a systematic approach is essential. You have to be very systematic and you have to read all the ECG slowly and carefully. And this is very important, not to miss anything. So, okay, we talk about the normal ECG. That means we are talking about the wave and the interval. Should know you have at the previous diagram we see the P wave and the QRS complex and T and U wave, and we will speak about this in details now. Here, if you see, we have this is a normal ECG. That means the P wave shape is normal and it is duration and interval is normal, and also normal the QR followed by the QRS complex, and T wave and U wave with normal QRS interval and QT interval and duration and shape. Okay, we will take each one separately. Here, normal in the progression of R wave. So we have to bring all the 12 lead ECG together to say it is normal. Okay? Because the progression from the progression especially of R wave from V1 and up to V6 should be normal. And if we don't know the normal, definitely we don't know the abnormal. So we have to know the normal first. And here are the 14 points that we should be and we should analyze carefully in every ECG. We have the 14 point. First one, number one, is standardization, calibration, and technical feature, including lead placement and artifact. We'll talk about what the calibration and what standardization. This is why I focused on that ECG paper and the small square and the big square and what it represents and how we calibrate and standardize our ECG. Okay, what does that mean? That means the caliber of ECG should I will tell you how it will be by seeing an ECG. Then what we have to analyze the rhythm, number two, and the heart rate, and the PR. So the interval here will come, the PR interval, and AV conduction. That means every PR or P is followed by the QRS complex and the QRS interval and the QT interval and the corrected QT interval and the mean axis of the QRS, the P wave itself, the QRS voltage, and the precordial R wave progression, and the abnormal Q wave, and the ST segment, and T wave, and lastly U wave. And this is the hallmark of reading the ECG, and it is the hallmark. I always say waves and interval. These are waves and interval. Okay. Okay. Then see what is standardization or calibration. Here, the first step while reading ECG is to look for whether standardization is properly done. Okay, if it's not well calibrated, the other interpretation of the ECG will be wrong. So we have to the first step of reading the ECG is to look for the standardization. Is properly done or not? What is the standardization? Look for the vertical mark and see that the mark exactly cover two big square. That's mean 2 millimeter or 1 millivolt. Told you before that one big square is equal to 0.5 millivolt. So the vertical mark, this is a mark on the ECG. You will see this mark in the ECG. This mark should cover two big square. That means it's 10 millimeter or 1 millivolt, because one big square equal 1.5 millivolt. That is the amplitude of the ECG on the graph on the ECG paper. So, and the velocity of the ECG, what that means, that the it is the velocity of the ECG is 25 millimeter per second. 25 millimeter per second. That means this ECG paper goes every second it crosses 25 millimeter. Goes 25 millimeter per second, and the amplitude is 0.1 millivolt per millimeter. 0.1 millivolt per millimeter. That means every small square equal 0.1 millivolt. This is the standardization, and this is very, very important. Then we should know this. We look at this. We took the ECG pager. We should look at that it is well standardized and calibrated that the velocity is 25 millimeter per second, and that is the caliber is 0.1 millivolt per millimeter. Here, that is it. That is it. You see here the first box on the left here. This one. This is well standardized here. This cover two big square. That means this is 10 millimeter per millivolt, and here it's not like that. This mark cover only one square, and here this mark cover 1, 2, 3, 4 square. This is a calibration. This is the normal one. That's 10 millimeter per millivolt. 10 millimeter or 0.1 millimeter per millivolt. This is the right one here, and this is half, and this is double. Okay, this is unbelievable. You can do it like this for some purpose, but you should look at this first. Okay, the second one is the rhythm. Okay, on the rhythm, we need to know this rhythm is regular or irregular. That's irregular. That means R to R interval are equal or not equal. Then the rhythm, is there any P wave before every QRS complex? Normally, every QRS complex should be preceded by P wave. This is and there are any abnormal beats. That's abnormal beats, not like other beats in its shape. You call this abnormal beat. Here, like this, if you see, it is regular here. It's regular, and that means RR interval is equal, and that's every QRS complex is preceded by P wave, and no abnormal beats. So this is regular here. You get me? Okay, I will explain more in the coming lead. Okay, the rule, the heart rate. We have what's called rule of 300. This is for regular rhythm. The rule of 300 for regular rhythm, or you can use the 10-second rule for irregular rhythm. So determining first, is it regular or irregular, and to calculate the heart rate. If it is regular, you can use the rule of 300. If it's not regular, you can use the 10-second rule to calculate the heart rate from the ECG paper. Okay, here we will explain more and more. Don't worry about that. The rule of 300, we can count the number of big boxes between two QRS complex and divide this into 300 small boxes with, or if you use the small boxes, we can use 1500 for regularism. It is the same. You can use the big square to calculate the heart rate. And for the smaller boxes, we can use that 1500. Do you think why we use this? What's the point beyond this? Why we use this? We have to understand that it is a simple calculation. It is a simple calculation here. You see, this is again the ECG paper. This is the ECG paper. We have one big square, then divided into 5 small boxes. Here, this is only a large. You see here, this is it is equal 1 millimeter vertically and horizontally for a small square. 1 millimeter. Then so it is a half, and the big square is a half centimeter, and this is a small square is 1 millimeter for each. Okay. Speed of recording here. Why we say this? Well, was the speed 25 millimeter per second. That means 25 small square per second. 25 small square per second. Okay, 25 because one small square is equal 1 millimeter. That means these are 5 large square. Okay. So 1 second equal 25 millimeter. 1 second equal 25 millimeter. What does it mean? If 1 second of time pass, that means 25 millimeter passed, or big 5 big squares. Again, here I told you 1 millimeter equal 1 small square, and 1 second equal 25 small square. That's here by squares here by square. Then that's 1 small square equal 1 millimeter. Just I want to explain you the calculation. 1 large square equal 5 small square. So 1 second equal 5 large square. See, this is clear and simple. So you know 1 minute equal 60 seconds. So we have to multiply 60 by 5. This will give us 300 large square. So, sorry. From here we have the rule of 60. So 1 minute, if you multiply by small squares, 60 by 25, it's equal 1500 small square. So if you use large square, you can use 300 rule. If you use small square, we have to use 1500 rule. That means the number of large square in minute are divided by number of large square between two R wave. This is give us a heart rate. Here it is. Here if you see, this is regular. Using this is regular. This here 4 large square, if we calculate them, 4 large square, 1, 1, 2, 3, 4, like that, between two QRS complex. This is a rule of 30, how it works. Uh, 1, 2, 3, 4, 5, 6. Between two QRS we have 6 large square. So divide 300 divided by 6 equal 50 beat per minute. Simple like that. So what's the heart rate here? Calculate 1, 2, 3, divide 300 by 3 and equals 100 like that. Or by 4 here, 300 by 4 equals 75 beat per minute. What's the heart rate here? 300 divided by 1.5, it's 200 beat per minute. So this is the rule of 300. It's very simple. Only we calculate the big squares between two two QRS complex in a situation of regular heart rate, and divide 300 by this number of large squares. You see here 300 divided by 4, because we have 1, 2, 3, 4 big square between this QRS complex and this QRS complex. Okay. I think this is clear. This is one QRS complex and this is one QRS complex. We have 1, 2, 3, 4 big square between two these QRS complex. So this is why we divide 300 with 4. This is equal 75 beat per minute. Simple like that. Simple like that. Okay. So what is the rule of 10-second rule? Here we count the number of beats present on the ECG during 10 seconds. That's 50 big squares, and multiply them by 6 for irregularism. We use the 10-second rule for irregularism. You count the beats here. That means the number of the QRS complex during 10 seconds. That means 50 big square and multiply them by 6 to make them 60. This will give us 60 seconds. That means 1 minute. It's very simple. The idea is simple. Okay. 10 seconds means that 10 seconds means 50 big square, right? 10 seconds, because 1 second 1 second equal how much? 1 second equal 5 big square. So 10 second equal 50 big squares. This is 10 second. We need 60 second. We multiply this by 6. This is equal 60 second. That's 1 minute. Simple. Here it is. What is the heart rate? Here 33 times 6 equal 109. What actually what they do? Here you calculate the heart rate, and here this ECG we can calculate 50 big small squares. 50 big sorry, I mean 50 big squares. Calculate 50 big squares, and then determine this 50 big square and calculate the number of the QRS complex in this 50 big squares. Then we'll multiply this by 6. This gives us the heart rate. We use this rule in the when the heart rate is irregular. So this is very important to know when the heart rate is regular to calculate the heart rate. This is the normal interval, and this is a P wave duration. It should be equal or less than 120. This is the normal, and for the PR interval, it should be less than 200, and the QRS duration less than 120, and the QT interval, the corrected one, from 440 up to 450. Okay, talk about the PR interval and the P wave and the duration. From where the PR interval come from? Here, see, this is the PR interval from the beginning of the P wave up to the Q wave. The PR interval. Okay, it represents atrial depolarization. This is a dotted line here, and plus delay in the AV junction. Okay, the AV node bundle of his AV junction and the AV node itself and the bundle of his. This is the PR time represent or the interval represent the atrial depolarization plus the delay in the AV junction. AV node will bundle of his here. What the idea behind the delay? The delay allow time for the atria to contract before the ventricle contract. So the atrial, the delay here to allow the atria to finish to contract and before the atria. So here we have the AV delay, AV delay, AV delay. Okay, you see here the dotted line here represent the, 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 the duration of the E E I mean the PR interval, the PR interval. So the normal PR interval is from 0.12 second up to 0.20 second. That means 3 to 5 small squares. 3 to 5 small squares. We have short PR interval. What's called Wolff-Parkinson-White syndrome. That's inherited arrhythmia. We have a short PR interval because we have another accessory pathway that bypass the AV node. So this makes it very short. And the long PR you see the PR in the first degree AV block. The first degree AV block. Here an example of the prolonged PR interval. The first AV block. This is the first AV or first degree AV block. Here the PR interval is equal to 0.28 second, or we can say 280 millisecond. You see here. Use this pen. Here, this is a P wave here. The duration of the P wave from here up to here. If you count this, it is more than one big square, more than 5 small square. So it is prolonged. We have prolonged PR interval here. This is what's called first degree AV block. First degree AV block. The same here. In the other example, also from here up to here, it's almost equal to big square. The short PR interval, we have this in the WVW, or Parkinson-White syndrome. Here we have an accessory pathway that is what's called bundle of Kent, allow early activation of the ventricle delta wave short PR interval here. That means we have an accessory pathway that conducts the electrical activity. the electrical current does not come by the usual AV node, and so there will be no AV delay, and there will be another short circuit that pass electrical activity to the heart, so there will be very short PR interval. This is called and give us what's called the delta wave here, and the shortness of the PR interval. If you see the red line here represents this delta wave here. This is a delta wave, like a delta. Here, this is a delta wave in the red one, and this is a P wave here. Right, this is why it's shortened, the P wave. And this is what's called WBW syndrome. If you hear the cyanoatrial node here, we have the cyanoatrial node. And this is the AV node, and we have the abnormal. This is the abnormal current goes through it. Sorry. This is here an example of short PR, short PR interval. It's very short, it's less than the normal here.